There's clinical data that shows that with radical or robotic prostatectomy, 20% of the time they leave positive margins because they cannot differentiate. When they're in the MRI, they can either see it or they suspect because they see majority of the cancer. So we literally created one of our modules, and this module allows them to provide extra heat to that one region. So if they say, well, gee, I think I might have some extra margin here, I want to make sure that there's no cancer left, they can just blast. It's like a blaster. So you blast a little bit of extra heat, there goes an extra millimeter or two and gives them a much more confidence. So you're exactly right that approach really, really works.
Welcome, MedTech Gurus. Today, as I mentioned in the introduction, we have an amazing guest with us, Arun Menawat, the CEO of Profound Medical. Arun has an impressive career in medtech with decades of leadership experience in imaging and surgical technology. An engineer by training, Arun has successfully led multiple ventures, including taking Novadac Technologies from a startup to one of the fastest growing companies in the NASDAQ. At Profound Medical, he and his team are redefining prostate cancer treatment with Tulsa Pro, an incision-free, image-guided therapy that aims to eliminate the debilitating side effects traditionally associated with prostate cancer surgery. Arun is also helping shape the future of AI in medtech and is leading a landmark trial comparing Tulsa head-to-head against radical prostatectomy, a long-standing gold standard for prostate cancer. Hey, Arun, are you ready to be our guru today?
Thank you, Tom. Absolutely. I'm excited to be here.
We're excited to have you. So, first of all, tell us something fun about yourself or your family so we can get to know you a little better.
Well, there is a lot of fun. I just turned 70. I have been married for 45 plus years, have two wonderful kids, both in healthcare. So it's great to be part of the family, actually.
Well, I have to tell you, you look fantastic for 70. So congratulations with that.
Thank you. Thank you.
So Arun, tell us a little bit about Tulsa Pro, first of all, and how the procedure works and what makes it such a breakthrough for patients. Can you provide us a little background here?
Absolutely. It is indeed a breakthrough. So the key here is that there is no incision and there's no hospital stay for patients who undergo this. So the way I like to talk about it is that just imagine a day when a patient can be diagnosed with prostate cancer in the morning. With our technology, they can be treated in the afternoon and they literally go home and they can just tell their family, hey, I was diagnosed, but I'm treated and it is confirmed that I'm cancer-free. And so that is why you're right. It is a game-changing technology. And the reason we can deliver something like this is because, the prostate region is really congested. And so what happens is that when you remove the prostate or when they radiate the prostate, they're always killing nerve bundles or they're killing the muscles that control our urination. But with us, we are able to visualize in real time by using an MR. So we treat the patient in the MR. So the physician who is treating can actually see what they're doing. They can avoid killing those. So it's in that sense, it's actually a very simple idea is you can show them all of the anatomy. They can make sure they kill the cancer and not kill anything else. And then we do it with a unique ultrasound-based technology. And that allows for the fact that there's no incision and no blood loss. So it really is, it allows us to do things that nobody has ever been able to do before.
Oh, that's phenomenal. I have to share with you, I'm a veteran of many years in the OR, and I've actually seen a open prostatectomy back in the day. I've seen minimally invasive ones, and then I've seen several, I don't know how many, probably a couple hundred robotic ones. And I think what you're doing, as I did my research, is really exciting, and I think it really can be a game changer.
Thank you, Tom.
Yeah.
Absolutely.
In doing my research, though, I noted the Tulsa Pro is non-invasive and highly precise. So, that type of thing doesn't come easy. So I'm kind of curious about what were some of the bigger technical hurdles or clinical hurdles your team faced in bringing the solution to market? Can you walk us through some of that?
Absolutely. So indeed, have been number of challenges. So, we're used to seeing the MR as a diagnostic device. We go in, we get the imaging done, and then the soft tissue is visible. The physician can tell us what's wrong or if there is anything wrong. But here we're actually treating inside an MRI. Now, MRI uses strong magnets. So anything that we put and if you've undergone an MRI, they won't allow any metal to go in the wound and things like that. So we had to really develop both hardware and software that can actually go into the MR, and that all of the technology or all of the controls have to be outside of the MR, because the surgeon actually sits outside and it's all remotely controlled automatically, right? So we have all the complications of combining the MR image with a robotic system that is compatible with MR. We had to develop a heating system that was entirely different. In fact, I don't believe there's anybody else who can do this. And it allows using sound to gently heat the tissue rather than create some hot area where you can transmit sound or transmit heat. And so it is image guided, it is robotic, it is heavy duty, software driven. It has to use AI by design. So all of the challenges were there, and we put it together, and that's why we're actually proud of it, and that's why it's also a very elegant solution.
Yeah, this may be an oversimplification, but I'm thinking like ablation. Is it more of like an ablation technique?
That's an interesting question, actually. It is technically considered an ablation, but it is not the ablation in terms of the connotation of the word ablation. When we think about ablation, we think about burning tissue. If you've been in the surgery suite, you're burning tissue, you can literally smell the tissue is being burnt, right? Versus this is not really burning the tissue. And that is really an important difference, because that is why our clinical outcomes are better. So what we're doing with this technology is we send sound waves into the tissue. The sound waves are absorbed by the tissue gently, very, very slowly. The MRI, we all think about the MRI as an imaging device, but it is also a device that can measure the temperature of the tissue. So it functions like a thermostat. So sound goes into the tissue, gently the temperature goes up, the MR sends the temperature, and the computer automatically then sends more sound. When it hits between 55 to 57 degrees centigrade, it automatically stops. So we're never burning the tissue. Now, the reason we get to that temperature is because at that temperature, tissue instantly dies. That's the minimum temperature at which tissue instantly dies. And when it dies, the body doesn't react to it. The body says, oh, I have some dead cells. Now, there are lots of dead cells in the body. So the body says, well, I got to sweep it and reabsorb it. And so what happens is that gentle heating creates cell collapse. And that cell collapse, body just absorbs it. So these prostates, once they're treated, our clinical data shows that 90% of the prostate is just absorbed over time, and they just shrink down just to the urethra, which is the useful part of the prostate.
Wow, that's remarkable and a terrific explanation. Thanks for that. It really kind of helped
Thank
bring
you.
that home. And I noted in doing my research, you're currently running a head-to-head trial comparing your Tulsa Pro with radical prostatectomy, if I've got this right. That seems
Yes.
maybe a little bit risky to me, and I'm kind of curious why you took this approach, and from a commercialization standpoint. And what are you thinking the demonstration and the trial results will yield for you and your team?
You're right. We're entrepreneurs, and we are doing big things. And that's what we do. That's what all entrepreneurs do. And so, I mean, prostate cancer is the largest cancer among men. And second leading cause of death, I think, lately. And the robotic prostatectomy or radical prostatectomy, um, you know, it's well known that there are serious side effects with it. But at the same time, it is the best available technology today and is as close to standard as there are. But one of the things that, as you can imagine, is that when you have a large market and you have such significant issues with the current standards, there have been over time many new technologies, the many new ideas that have come, and they have really not been adopted in a standardized way in a majority of the patient population. There are a few that are very specialized and they apply to a small subset of population. But our goal is to really go after the mainstream market because we can treat vast majority of the patient population. And that is why we felt that we needed to be able to demonstrate that through a head-to-head clinical trial. Now, am I optimistic? Of course. Let me share with you just some key points. So first of all, as I mentioned, we know very well that we've treated well over 3,000 patients commercially. There's no blood loss with our treatment. There's no hospital stay with our treatment. We haven't had we haven't had any safety issue. Patients have not been, we haven't had any patient death. We haven't had any class 4 disease complications. That inherently, when you have a radical prostatectomy or robotic prostatectomy, there is significant blood loss. Patients who have diabetes or comorbidities like heart disease, which older men tend to have, it's a problem for them, right? There's no hospital stay. So, and the safety data is so strong that we think that it actually makes a lot of sense to be able to head-to-head show there is a technology where if you're diabetic, heart disease, you're going to have to be off of those drugs for, at least a week prior to it, maybe a week or two afterwards, versus here, you can actually get a treatment done without any of it. We're actually treating some patients in multiple sites, patients who have a pacemaker already in them. So I really think that to be able to show these benefits, it's likely to be, I think we're in pretty good shape. Obviously, the data is going to tell, which is going to come out within a week or so. But I think inherently, this technology is superior, I believe.
Yeah, that's fascinating. And I hope I don't put you on the spot with this, but a radical prostatectomy in everyone that I've seen takes somewhere in the neighborhood of 4.5 to 6 hours on average, sometimes a little less, sometimes a little longer. So the patient's under anesthesia, going under a lot of stresses. What's kind of the procedure time for your approach?
That's a great question, actually. So the radical prostatectomy has gotten better over time. But we kind of measure it in days, number of procedures per day. And the reason we do this is because lots of companies will come out and say, well, I can save you 10 minutes. And the surgeon sort of said, well, that really doesn't do much for me. And so we said, well, what is the best way you can measure that really does something? And they said, well, if I'm doing 2 cases of prostatectomy and you can show me I can do 3, well, then that matters to me. So what we have been able to show that those who do 2 can actually do 3. Those who do 3 can actually do 4. We have actually a couple of cases where the particular surgeon actually does 4 procedures, long day for him, but the same surgeon has treated 5 using our technology. And if you look at objective data from CMS, they basically talk about, to the points that you mentioned, about 4 hours of procedure time is what they pay. They base the payment for prostatectomy on that basis, and ours is about 20% less.
That's fascinating. And sorry to get this granular, but this is interesting to me because when I look at the radical prostatectomy, the surgeon's doing a lot of manipulation with their hands and the team and all that. And with your approach, it seems like it's a little less intense with the mechanical manipulation. Am I heading down the right track with that?
It is a step change, to be honest, in terms of that. Because just think about this. They insert cystoscopes every day. They know how to do that. And so they insert a tube that is same diameter, uh, that is cystoscope. That takes them 5 minutes. And they're very comfortable. They don't really have to think much. Then they go sit in the control room. They don't touch the patient. The images show up. They click a button. The AI says, here's the boundary of the prostate. And all they have to do is say, okay, I either like it or I'm going to make a minor change. And there's a pen on the screen and they allows them to change it if they choose to do that. Once they have accepted the treatment design, literally they click a button and the treatment itself is completely autonomous. So they're watching the screen and they're only interfering if they see something is wrong, which is not very common, to be honest. So I've had surgeons, they're watching the screen. These are good surgeons, but I've had lunch sitting with them while the patient is being treated. That is unheard of, right? And as we talked about already, we are heavy duty on AI. So more and more of this procedure is getting automated as time goes on. And in fact, we're going to be announcing our next version next week, a week from now at the AUA.
Wow, congratulations. And thank you for that explanation. That's really helpful and kind of brought things home for me. I want to switch gears just slightly here because I'm also fascinated. Your career has been deeply rooted in imaging technologies and innovation. And I'm wondering if you can kind of walk us through how that expertise and background shaped your approach to the innovation at Profound Medical. Can you take us through that journey?
I'm very happy to. There has been a real purpose behind everything that I feel like I do. And when I was at NIH in the late 70s and early 80s, a lot of development was going on. And we were finally, for the first time, starting to look at the human body from the perspective of engineering. And so I was really fascinated that a lot of the work that I did, the research that I did, related to how you can measure blood flow in arteries. And you could sort of figure out which parts of the arteries, like coronaries, that have more higher tendency to get blood clots. So imaging very early on had a big impression on me. And so I was at ISG Technologies, which later became Sidara, and imaging began to become important. These industrial companies like GE, Philips, Siemens, they knew how to make hardware because they were coming from industrial world. They did not know how to make software. So we were a software company and we said, we're going to be able to take your data and show you the images on the screens. And as that market grew, the thing that started to really resonate with me was, well, if a diagnostician can do an early detection and better detection using imaging, how can we take that imaging and give it to a surgeon who's literally treating that patient? How can we improve the surgery? Because that's even more. And so we went from being an imaging software company to the next company, which was Novadac, where we said, we're going to be able to show you a fluorescence imaging platform so you can get very quick images. Within 15 seconds, they could see the blood flow. They could see the perfusion. They could see what part of the tissue is getting more blood flow, which tends to be cancerous. What part of the tissue is getting less blood flow and might die over time, so they might as well take it out of the body. So much more clinically intelligent decision-making because of this technology. And then I kind of said, the third leg has to be able to come up with a way to make imaging an inherent part of improving surgery. And that's what Profound represents to me. So I am, as you can tell, really passionate about it. I really think this is game-changing. Quite frankly, I think this is the wave of the future. We want to be able to take surgery into the Star Trek realm where patients can be treated from these serious diseases. And as much as 99% of our focus is on prostate, we have started clinical trials on pancreatic cancer, liver cancer. So I think this whole idea is going to be beyond prostate in the next 5 to 10 years.
Yeah, that's fantastic, and thank you for sharing that. And I'm also curious because you mentioned AI, right? And that's kind of the big buzzword today. But
Yes,
you're integrating AI into your technology platform, and I don't think that's an easy step to take, especially with something as specific as what you're doing. So I'm kind of curious about what are some of the lessons that you learned in trying to develop this integration, and what can you share with our gurus out there that might help them on their journey?
absolutely. I would be happy to. So I think to some extent we were a little bit lucky because the procedure, the technology itself was so complicated that AI, the need for AI was almost a must. So we started thinking about AI 4 years ago, 5 years ago. And we said we really needed to invest. And we did it confidentially at the time because it is interesting that within the last 2 years, all of a sudden AI has gone from a sort of, oh, this AI person, don't want to talk to him, to, oh my God, this is here, right? And so the way we approached it, I think this might indeed be helpful, is we said it's not about the AI, it's about what AI does for you. And so the general principles we started with was the foundational principles, better, cheaper, faster, easier to use. So we said, well, when we go with this new technology, we're going to be educating the urologist in an entirely new way of doing it. How can we use AI to make it really easy? So the fact that our AI can show them these are the margins of the prostate, that makes it so much easier for them to see it and so much faster for them to do it. And they know that it's designed after thousands of images of being able to do it properly. So it gives them confidence and at coming in with a new thing. And so that is one principle we used. The other principle we used is anything that is repeated, you know, can be standardized. And so we said, well, if we can be standardized, then it can be automated. So we're doing that. The third thing that we're using it for, which is, I think, going to be actually very big, is we're able to figure out what type of patient this is. We can see the regions of the cancer. We can see microcellular structure because we have the MR. So we're able to actually design the treatment plan that I think over time will show that it is going to be better than what the human eye can see. And we're not quite there yet, but that I think is the principle we're using is can we use it to make it better, cheaper, faster, easier used, and then be able to use it to literally uh, treat where surgeons cannot see. And I really, really think we'll be able to significantly improve outcomes as a result of it.
Yeah, that's interesting because I always watch surgeons, and I think the thing that gives them probably the most heartburn is, did I get everything at the margin? What was behind, what
Yes.
was hiding behind adjacent tissue that you can't see, right?
Yes.
And if
That
you
is
can
the, yes.
solve that, right?
Yes. That is the number one thing that well, once they saw our technology, absolutely, Tom, that was the number one thing we hear from them is that there's clinical data that shows that with radical or robotic prostatectomy, 20% of the time they leave positive margins because they cannot differentiate, right? When they're in the MRI, they can either see it or they suspect because they see majority of the cancer. So we literally created one of our modules, and this module allows them to provide extra heat to that one region. So if they say, well, gee, I think I might have some extra margin here, I want to make sure that there's no cancer left, they can just blast. It's like a blaster. So you blast a little bit of extra heat, and it goes an extra millimeter or two and gives them a much more confidence. So you're exactly right that approach really, really works.
Yeah, that's interesting. And you touched on education, which always interests me as well, because we all know surgeons, and I've interviewed surgeons. I've got friends that are surgeons, and they all admit how stubborn they are, and all of that. So God bless them for that, because they know what works. But when you're approaching the education piece on something as novel as this, help our gurus out there, because we all want to learn. How did you approach that, and how did you get their buy-in with some of this?
So you're right. Education in a company like ours is a very, very big topic. And we have invested heavily in it. I cannot tell you that we're great at it today. I think we're pretty good at it, but I would like to continue to invest and get better at it. We're doing a number of things. So first, we only went to the earliest of the early adopters, because the earliest of the early adopters were already saying, I don't want to do robotic prostatectomy. I already know this is no good. So that hurdle to say, we're bringing something new, they wanted to hear you're bringing something new. And then when we went through the simplicity of the logic of our technology, these early adopters, first 10 guys were pretty much, hey, I like I like what you're telling me in science. I'm going to confirm it myself, but I'm ready to try it. And that approach really, really worked for us. So then typically every one of them did a minimum of 50 cases on their own. And they said, yeah, I think this technology has legs, because they could see that their clinical outcomes were actually at least as good as our clinical trial data, or they were better in some cases. And they could see that they could treat patients that could otherwise not treat. So that was the first thing we did. Then we said, well, okay, if you guys have made your own conclusion, can you become the educators for us? And so we do two very controlled things. We do with some very high degree of repeatability. One is we do video conferences or virtual conferences where surgeons who are using the product talk about unique cases. They will say, I treated a prostate that was 260 cc. That prostate would be very hard to remove. I treated a prostate where the patient had some other technologies that were used prior and I was still able to use it. Or I treated a prostate, which is a very high risk cancer, but I was able to blast it outside, um, and so on. So they are educating their peers by using their own data. And we encourage them to talk about unique cases, because that also gives the urologist the ability to understand that normal day-to-day routine cases will be even easier to use. The other thing that we do, which does really well for us, is that as we went after the entrepreneurial physicians, we also went after teaching hospitals in the beginning. And teaching hospitals had a different take on it. Their take was, well, listen, I'm the Stanford, or I'm MD Anderson or Johns Hopkins. If I cannot afford not to have the latest technology. Right. So it wasn't like, I believe you or this or that. They just said, well, I got to try it. And when they tried it, they also started liking it. And so those guys are now also coaches for us. So we do live conferences routinely, and we bring surgeons who are future users. So these are intense days. They come in 7:30, they start getting treatment. They start getting educated. And every bit of it is from the teaching hospital surgeons. Right. So these are two very specific things we really have invested in. But as I said, I think there are a lot of other things that we can do, and we're working on it. It is really virtual training for new users to get proctored virtually. We're so AI based, we think we can do a lot of virtual things. So there's a lot that we need to do, and it's a very important part of our strategy to grow the business.
Yeah, that's really helpful, and thank you for that, because that makes total sense, and I can tell you're on a path. And you mentioned Novadeck Technologies earlier. As we mentioned in the introduction, it went from startup to one of the Nasdaq's fastest growing companies. So our gurus out there are always interested in that kind of scale. So I'm just kind of curious about what lessons or best practices you learned as you scaled uh, or took from that experience to scaling Profound Medical today. Can you give us any insights with that?
Tom, I'm happy to talk about what I learned. A lot of the lessons I think entrepreneurs learn. So I'll talk mostly about what was unique that I thought was different. And the first thing was that, when you bring something that is game changing, you just cannot go to a physician and say, "Hey, I've got a new technology. What do you think about it?" As soon as you say, "What do you think about it?" their answer is, "Well, as we said earlier, I'm not really interested in changing. I want something that's proven because I'm feeling cancer, man. I'm not going to try something, right?" So, how you approach has to be, here is my clinical data. Here is the current problem. And it's not what do you think? It's hey, this technology needs to be adopted. Are you in or are you out? That's a very unique and a very different message, right? Because what you're saying is, are you willing to partner with me to do something unique, right? And there's the data that makes sense. Um, and so even when we were hiring salespeople early on, and salespeople say, "Well, I'm really good at listening to the customer." And my answer was, well, those are eerie lines to say. Every marketing book says, listen to your customer. It's really how you listen and how you communicate. That's where the trick is. And to me, that was the lesson I learned at Novac. In the early stage, you go out, say to them, "Hey, tell me your feedback, what you think," versus "Tell me, this is interesting technology. There's a real problem here. Are you willing to partner and be an early adopter or not?" And it's a very unique approach because it also says, if your answer is no, there's going to be another one who's going to say yes to me. So are you willing to let me go to the next one? And a lot of people will say, "No, I'm not willing to let you go." You know, so that to me was that balance is really important. Now it's going to be different for every company and different. But I think to me that balance of learning what does it mean to listen to the customer, that's the trick in my mind.
I wrote this down, right? How you listen is what matters, right? And
Yes,
it made me think that that engagement, right? Because that creates an engagement, and I'm willing to bet that that also brought a lot of additional potentials for innovation for you and your team. Am I heading down the right path on
absolutely.
that?
Absolutely. It created a relationship, and every new technology has its own rough spots. Like, sometimes they'll say, "Well, this design, I need you to change this design." And so you go from, "Okay, I know this is new. I'm willing to partner with you. But at the same time, man, I'm going to give you lots and lots of advice on what you need to fix." And what we did was we said, "Hey, we want this feedback." And again, a lot of companies say, "I want the feedback." But what we did was we said, "I want the feedback." Then every quarter, we say, "You said this was a problem. Here, we've fixed it." Right. And so then these surgeons started to come back and say, "Well, a lot of people say this, but you guys are the ones who actually do. You are actually listening to me." And that builds that credibility. And this is frankly why I have the confidence I do, is that our surgeons are really, really engaged with us, as you said. And our patients love the product because of that engagement. We also do a lot of patient education.
Makes sense. And the word I was thinking about when you were talking about that is, coming back with those fixes is trust, right? Because they
Yes,
know that you're willing and come back and go, okay, here's what we've done. Here's the modification of the change, right? And that just shows them that you're somebody they can trust, right?
they can trust. Absolutely. The word that we use internally every day is build credibility with our customers,
Mhm.
which is exactly the same thing. Yes.
Yeah, yeah, I love that. I love that. So, this challenge and this journey that you're on is one that I'm sure isn't inexpensive, right? So, with your career, I know you've had to do some fundraising, and a lot of our gurus out there are interested in finding investors for their companies. So, especially early on, right, when you're still in a conceptual stage and you're trying this disruptive thing that nobody's ever done before, how did you go about what were some of the best practices you used to speak to investors and start to build the equity that you needed to go forward into the market?
Yeah. You're right. Particularly for raising money for Profound has been harder than, frankly, for most other ventures I've done in before. And part of the reason it was harder was because there are lots of technologies. And so when I would go to an investor, they would say, listen, robotics is the standard, radiation is big, hospitals already have this equipment, and there are, five other technologies that have come and gone. What makes you think that you're going to be successful in such a competitive and difficult environment? And so it was most certainly very hard. You know, there is no simple answer to that question, to be honest. But the real honest answer is honesty really pays. And so what my strategy was, certainly I benefited from the fact that, I had credibility from the past. So that credibility allowed me to open the doors. And for entrepreneurs, if they have not done it in the past, they should have board members who have that credibility. But I was able to open the doors. And then I showed them a realistic picture. Said, this is, yes, we're using an MR and nobody's ever used an MR for treatment, but here's why it is a natural step. Here's why MR adds value. This is not a gimmick. This is our strategy. We want to do clinical trials. We want to develop the software, which will be an amazing competitive advantage. Uh, we were able to bring a few surgeons who were able to talk about the fact that there is a real unmet need and that this technology could indeed solve the problem for the majority of the patients and not just the niche patients. And so that honesty and really laying out that we raised this much money, we're going to deliver this for it. Then delivering that to be able to say, I delivered what I said. Now let me go to the next step. Those are like, these are not necessarily things that you don't already know, but really, again, executing thoroughly with building that trust, as you said, was the way we went about it.
Yeah, yeah. Thank you for that. So, Arun, this seems like a really exciting time for you and your team at Profound Medical. Where are you going from here? What does the future hold?
Well, first and foremost, I think that we want to be treating the patients for prostate disease, not just cancer. We are going to introduce a new software AI-based module that will allow physicians to treat BPH, patients who have BPH. Also, a large number of these patients have some cancer lingering around, hasn't been found. So we think that because we can do both, we'll be able to give them confidence that this is the best technology. So that is a big priority for us this year. We also feel that it's time for MR to become interventional MR. So just like operating rooms, hospitals have a robotic suite, they should have an interventional MR suite. So we partnered with Siemens for now. We will be partnering with Philips and GE over time. And the idea is that we think that hospitals will have in the future in interventional MR suite where our technology will go for prostate. There's another company that is developing incision-free treatments for brain diseases, which is also very important. There are many companies doing it for multiple things. We're going to look at other solid organs. So to me, long term, I think the most satisfying thing for me, for my life, frankly, is going to be that incision-free day procedure, no hospital stay becomes mainstay.
Oh, that's fantastic. And you know what? I think you're going to do it too.
Thank you. I
So,
will.
Yes, Arun, first of all, I'd like to acknowledge and thank you for the time it took for you to be our guru today and all the terrific insights that you brought us. If somebody wants to learn more about Profound Medical and yourself, is there a website? Are you on LinkedIn? How do we learn more?
We have it all. We have profoundmedical.com. We also have a LinkedIn site. For patients, we have a particular site called tulsaprocedure.com. It's a highly populated site with all kinds of really genuine education. It also has a form where if they want to, they can contact us. We provide at least 30 minutes of live training with an educated nurse. And if they choose at that point that, hey, Tulsa is good for them, then we recommend a number of sites that are closest to their location, and they can then go communicate with surgeons.
So fantastic. So Arun, once again, thank you so much for being our guru today. I enjoyed our conversation, and we appreciate all the insights you brought.
Thank you, Tom. Wonderful.
Thank you. Thank you for listening to MedTech Gurus. I am Sylvester Harris, your MC. If you want to learn more about Tom and his consulting services, you can go to www.pctmedical.com or email Tom at tom@pctmedical.com. Now, I can be reached at Sylvester Harris, that's SylvesterHarris 5048@gmail.com. And I'd be pleased to discuss any voiceover work that you may want for your company or broadcast. Hey, thanks so much for listening, and catch us on the next episode of MedTech Gurus.